How do you examine the mental status of a patient? The mental state examination is an important part of the psychiatric assessment. The examination involves observing and describing a patient's mental status at a given point in time under the domains of appearance, behavior, mood and affect, speech, thought process, thought content, perception, cognition, insight, judgment, and risk assessment. The aim of the mental state examination is to obtain a comprehensive cross-sectional description of a patient's mental status by observation and direct questioning, thereby gaining an understanding of the patient's psychological functioning. Demonstrate sensitivity and genuine empathy is vital in building rapport with the patient. Your approach to the mental state examination will help put the patient at ease. Be respectful and non-judgmental during the consultation. The first element of the mental state examination is appearance. We can gather much information by observation of the patient. The general appearance of a patient gives clues about the hygiene, ability to care for themselves, and their physical condition. Comment on the personal hygiene. Is a patient clean, unkempt, well-groomed? Look at their clothing. Comment on the patient's clothing. Are they wearing flamboyant color, or are they appropriately dressed for the weather? If it's freezing outside, are they wearing shorts and shirts? Comment on the physical appearance. Does a patient appear older or younger than their age? Do they have any signs of physical problems, such as are they jaundiced? Are they malnourished? Some patients may show distinctive features, such as they may have tattoos and signs of needle track marks. It's important to comment on these distinctive features. The second element is behavior. This is about the general demeanor of the patient. How engaged are they? How easy is it to build rapport with the patient during the interview, the attitude and body language? Comment if you observe the patient is distracted, is suspicious, or appear to be engaging with hallucinations. Comment on the eye contact. Are they keeping eye contact, or are they avoiding eye contact? What are their facial expression? If you observe psychomotor activity, these are psychiatric disturbances that manifest in changes in motor function, such as psychomotor agitation, psychomotor retardation. That could be akathisia, tremors, restlessness, and tics. Comment on these psychomotor activities. The third element of the mental state examination is mood and affect. It can be difficult to differentiate between the mood and affect of a patient. If you're not sure what is mood and what is affect, mood is what the patient tells you, and affect is what you observe. Mood is the patient's internal emotional state. It is described using the patient's own words. Example, I'm happy, my mood is low, I'm anxious. To evaluate a patient's mood, it's important to ask the patient directly. Questions such as, how are you feeling? How has your mood been lately? Will help you to gather information about the patient's mood. Affect is external. This is a clinician's objective assessment of the patient's mood. This is what the patient's mood appears as. There are several aspects to affect. The first one is appropriateness. The second one is intensity, and the third one is range of the affect. Appropriateness of affect is whether the mood is congruent to the affect. If a patient expresses that they are sad and the affect appears that there's sadness, then the affect is congruent to their mood. However, if a patient talks about a distressing event and is laughing, then the mood and the affect are incongruent. Incongruent affect is associated with schizophrenia. You can also comment on the intensity of the affect. Is the intensity heightened? Some patients who have personality disorders may be more dramatic and the affect may be heightened. The emotions may appear to be exaggerated. Some patients may have a blunted affect or a flat affect. In schizophrenia and major depression, patients may have a flat affect. They don't show much of their emotions. The next part of affect is range of affect. Some patients may have a fixed affect, in which case they don't show much of changes in their affect, whereas other patients may have a labile affect, in which case they might show that they are very depressed or they are happy the next moment. The fourth element of the mental state examination is speech. The speech of the patient gives a lot of information. The first thing is rate. Is the patient speaking at an increased rate or at a decreased rate? Some patients who suffer with mania may have pressured speech where they have a very high rate. Patients suffering with major depression may have what we call a poverty of speech, where the rate of speech is slow. There may even be a delay in speech. The tone is important. Patients may have a monotonous tone in depression and schizophrenia, or a tremulous tone in anxiety, or they may have a high tone in bipolar disorder. Comment on the quantity. Is a speech minimal or overexpressive to questions? Also comment on the fluency and the rhythm. Is a patient fluent and articulate, or is a patient slurred or stammering? The thought of the patient is crucial in the mental state examination. Thought can be described in terms of content and process. Thought content may include delusions. Delusions are fixed, false, unshakable belief based on incorrect inference about external reality that is not amenable to change in light of conflicting evidence. Persecutory delusion is a common delusion seen in schizophrenia. This is where the patient believes that one is being persecuted, harmed, attacked, or conspired against. Other delusions include referential delusion, belief that gestures, comments, or environmental cues are directed at oneself. An example is patient watching TV and find that the anchor news has made a gesture at him or her, and this is a cue that is directed to himself or herself. Delusion of grandiose is where the person believes that they have exceptional abilities, wealth, or fame. Erotomania is where the person has a delusion that there's somebody who is in love with them. Nihilistic delusion is a conviction that a major catastrophe is going to occur. Somatic delusion is belief focused on bodily function or sensation. Delusions are different to overvalued ideas. An overvalued idea is an untrue or exaggerated belief that is sustained with much less rigidity than a delusion. Example, anorexia nervosa. Other thoughts content include obsessions, phobias, suicide thoughts, and thoughts possessions. Thoughts possessions include insertion, withdrawal, and broadcast. This is where somebody believes that somebody is controlling their thoughts, inserting thoughts in the mind, withdrawing thoughts, or broadcasting their thoughts. The second component of thoughts is thought process. This is about how the mind is working. We need to evaluate the patient's rate, flow, and form. Are they making logical coherence of thoughts? Example, are they thinking linear, logical? Are they goal-directed? Or they may have a disorganized thought process. They may have flight of ideas, which are thoughts so rapid and incoherent. You might find derailment of thoughts or tangential thoughts or circumferential thoughts. Thought process that goes off a tangent and never returns to the matter at hand. Perception is the way we organize, identify, and interpret sensory information to understand our environment. Common perception disorders include hallucination. This is a false sensory perception in the absence of stimuli. Patients may experience visual, auditory, tactile, or olfactory hallucinations. It is important to ask sensitively about hallucination. You could ask patients whether they are seeing things other people cannot see, or whether they are hearing voices that other people cannot hear. With auditory hallucination, it's important to ask whether the person is speaking in first person, second person, or third person. Auditory hallucinations usually present in third person. This is where a patient might experience that somebody is commenting on what they are doing. Pseudo-hallucination is where the patient is aware that the hallucination is not real. Illusion is a distortion of the sense. Example, mistaking a shadow for a person. Other perceptual disorders include unusual experiences that are depersonalization and derealization. Depersonalization is a sense of detachment from their own personal self. Derealization is a sense of detachment to the external world that seems unreal. Cognition is important in the mental state examination. We need to assess the patient's level of alertness, orientation, attention, memory, visuospatial functioning, language functions, and executive functions. Cognition can be tested formally using the mini mental state examination. The abbreviated mental test score is also a tool you can use to assess impairment in cognition. The next part is insight. Insight is having awareness of illness and the need for help. Patients with insight understand they have a mental health problem. They can make a reasoned decision to comply with treatment and identify that what they are experiencing is abnormal. We can evaluate patients' insight by exploring their explanatory account of the mental illness. This includes three components: recognition, compliance, and whether they can identify pathological process such as hallucination or delusion. A patient may have no insight, or may have partial insights, or may have full insights. Impaired insight is characteristic of schizophrenia and dementia. Judgment is the ability to make considered decisions or come to a reasonable conclusion when presented with a scenario or life event. You may ask a patient about a scenario and check whether they have judgment. Last but not least is risk assessment. Risk assessment is crucial in psychiatry. We need to assess the risk of suicide, self-harm, and harm to others. Don't be afraid to ask about suicidal thoughts and plan. Be sensitive in your approach. Use normalizing statement. Sometimes when people are down, they feel like they can't carry on. Have you ever felt like you want to end it all? Ask whether this is an active or a passive suicidal thoughts. Does a patient have a plan? What is a patient's intent? If a patient is assessed as high risk, then admission to a psychiatric unit may be needed. The risk assessment is important in formulating your management plan. If the patient had previous suicidal attempts, then document that in the notes. If they had any deliberate self-harm, also document that, or if they have any drug overdose. Let's recap on what we've covered today. We've covered the mental state examination. This is an examination to assess a patient's mental status. First thing first, we start with appearance, then we move on to behavior. We check the patient's mood and affect. We evaluate the patient's speech, the thought process, the content of their thoughts, whether they have any delusions, overvalued ideas, or any phobias or any obsessions. Then we assess whether they have any perceptual disorders such as hallucinations. We check the patient's cognition, the insights, the judgments, and we'll do a risk assessment to complete the mental state examination. Thank you for watching this video till the end. If you found this video useful, please smash the like button and leave a comment down in the comment section. This really helps the channel to grow. If you've not already subscribed to this channel, make sure you subscribe and ring the bell. If you want to learn more about psychiatric assessment, go ahead and watch the video I've made on taking a psychiatric history. Take care everybody, bye bye.